on Actuary and Funding, Don Luis Alberto Martinez, who is with us today and who is coordinating the activity with Maestro Jorge Alberto Romero Toral. So we have the representation of Panama as well. In the panelist, we have Don Fabio Duran Valverde from the ILO, Dr. Leticia Martinez Martinion from the Superintendencia of Health Risk of Dominican Republic, and Doctora Maria Luisa Mariño from the Economic Commission for Latin America and the Caribbean. Today, we will listen the experiences who are going to be shared in this panelist with the intention to have the knowledge and share the experiences so we can be able to make a strong exchange and promote the good practices in the topic of the relation of cost relations. The pandemic has faces us to a very complex situation where the first stage we could observe in the discussion table how we were centering in the health offer where we talk in a lot of funding, adding fundings on equipments that had to be done in emergency, on hospital infrastructure, on vaccine access, and the access on health systems turned into a problematic on public health. The effects started to felt in the social area while the pandemic were advancing, and now we have a higher compromise in the analysis of social services, including pension coverage. Because of this motive, we are very honored. I'm going to leave you with the Maestro Jorge Alberto Romero Toral, the specialist of the American Commission on Actuary and Funding from the conference, who is Bachelor on Economy and holds a Master on Social Studies in the field of Social Economics by the Autonomous Metropolitan University in Iztapalapa. He has collaborated in research on social security on the Senate of the Republic. He has a wide experience on research at UAM Iztapalapa and Azcapotzalco in fields of political economy. He has served as advisor to the Secretary of Rector's Office at UAM. In the public sector, he collaborated in General Directorate of the Public Telephone Localization Service. And at the Mayor's Office of Alvaro Obregón, he was coordinator in the General Directorate of Social Development, providing training on the construction of evaluation indicators for social programs. He also collaborated with INEGI. He has published several articles, and we welcome him and give him the floor. Thank you very much, Doctor, and good evening for all of that are connected to this webinar. Called COVID-19 and its impact on health costs in Latin America and the Caribbean. I'm going to talk you of the background, of the context of this webinar. The pandemic caused by SARS-CoV-2 virus forced governments to adapt, face the health crisis, making adjustment according to its development. International organizations as well as social security institutions continue to make efforts to control and mitigate the disease in accordance with the recommendation declared by the WHO, which are guarantee early detection to reduce transmission rates, work with all government sectors to keep basic health services and those caused by the spread of the disease, as well as the application of vaccines to reduce the cost of treatments for vulnerable, immunodepressed, and infected people. Implementing this recommendation generated direct costs, which implies substantial modifications to the health and social security system. In general, COVID-19 disease caused extra economic and social costs, but particularly in health sector. An example is the reconversion of hospital infrastructure to care the infected population. The low public expenditure on health put on evidence the backwardness that existed in the health systems, which was translated into inefficient primary healthcare and a lack of effective systems for the management of health emergency. This showed that having a financial sustainable health system could have translated into lower mortality rates. It is not yet known what would be the real impact on the country's finances will be in the medium and long term. So it is important to consider the following points. One, rethinking the spendings that governments make on health on an ordinary basis and the restructuring of the financial operation after the experience of the pandemic in order to be better prepared for any future emergency. And second, the health planning through a risk management approach to emergencies caused by any hazard, which with improvements in the existence infrastructure, increase on health sector position, training of health personnel, as well as improvement of supply chains, investment in the development of new technologies for the organization of health services, for example. The problem of the pandemic is not reduced only to the health crisis, it goes beyond. It is directly observed how, for example, it affected the health systems in the region and in particular the most vulnerable populations. It also widened the gap in access to health, increased labor precariousness. It also decreased access to education and negatively affected the economy of families, to mention some of its effects. In short, the relevance of this webinar lies on the untimely impact and the cost generated by COVID-19, which implies, in general terms, rethinking social security, reflecting on a post-pandemic stage. The objective of this activity is to reflect on the cost and financial impact of COVID-19 on the health and social security systems of Latin America and Caribbean countries in order to establish planning and risk prevention mechanisms. Once said that, I'm going to present our first panelist. That is Dr. Fabio Duran Valverde, who accompanies from the ILO. He's economist, specialist on social security with more than 35 years of work in the field of social protection, international expert with activities in more than 40 countries covering Latin America and the Caribbean, Africa, Asia, and Europe. The main areas of work include social protection financing, actuarial sciences and statistics applied to the economies of pension systems, health economics, social spending, informal economy, and poverty. Until 2021, he held the position of head of the Public Finance Actuarial and Statistic Unit of the Social Protection Department of the ILO in Geneva. He is currently Senior Specialist on Social Protection and Economic Development for Central America, Haiti, Dominican Republic, and Panama. We will give the floor to Dr. Fabio Duran and welcome to this webinar. Thank you very much. Good day, good evening, depending on the country you are. First of all, I would like to thank the authorities of CS for the invitation to ILO to participate in this webinar that is on the impact of COVID on health costs in Latin America and the Caribbean on health system. This is a system that is that we are very interested at ILO regarding the implications of the work context, including the systems of social health protections. For this reason, I am very pleased to participate in this panel. Not only to participate, but only to learn of the panelists that are with me today. To start, I would like to confess that after accepting this invitation from part of Dr. Daisy Corrales, and after meditating on what would be my intervention, and ask myself what could be my relevant apportation I face to a significant impact in this. I'm not going to use any PowerPoint presentation. I'm going to take advantage of this space to talk about some elements that I find interesting. So I was saying that it was a very challenging place because I think that there has been a lot of works commenting the impact economically speaking of the COVID-19. I believe that this is valid worldwide, and for the Latin America and the Caribbean region, it's also valid. Also, there have been commented and documented a lot on the efforts of the health systems and social security systems to face the crisis. There is a wide range of data on these efforts and on this additional investment that provoked the COVID-19. If we look on internet, a lot of sources and information. So this has been well documented. I will also say that with different scale of systematization according each country. So it is possible to conclude that indeed the countries did make an additional effort with the increase of cost to face the crisis, the health crisis. So sometimes I believe by the efforts that we have made of looking information for this session, that with different grades of systematization prevents having an adequate comparison. So we were saying that there is indeed an additional effort and it is well documented, but we should also say that the aforementioned it's not about of having the enough money to face the pandemic. In general, by the information that this information is presented and systematized. Evidently, we couldn't say that the majority of the governments have made an effort to prove that there has been a compromise and an answer to assign more money to the sector. But the main problem is how this information is presented, sometimes unexpected of the governments to document the effort. Let's talk. But the low systematization at the system level, perhaps in the hardest years of the pandemic, 2020 and 2021, makes difficult to have a strong conclusion, at least for the moment. We should wait so this information could be better systematized. So, as we were saying, this requires sometimes to generate all this information and to order this information in each country in a more systematically well. So perhaps it's soon to have all the information in an integral way so we can analyze that information. Several countries have informed of the causes, as I was saying, for example, the infrastructure reconversion, vaccine prevention, information for the public, a series of areas that imply a great challenge, but the countries haven't been very well to inform the behavior of the system of services and of spending. And I would say that we shouldn't treat this as some ill intention, but we have to understand the complexities of these measurements, because in the practice it's not easy. Also, there are some other methodological difficulties. Some that I'm going to say to have one as an example. When the cost of health is analyzed in relative terms, and strictly talking of costs and not of expenditure, the costs as a GDP percentage of the government or and the social security institutions, as normally the more adequate way of making this measurement, you could arrive to conclusions or important mistakes on measurements. And I'm saying this because the crisis particularly generated a contraction of the economical activities unprecedented, with a fall of the GDP and the public expenditure. And these two variables are precisely the ones that we use to measure the effort of each country in health investment. So even if in the cost and taking into consideration these indicators, as well as taking into consideration of the COVID pandemic, we could say that either the costs were increased or decreased, or it were the same. So as you can see, this is very difficult, and therefore to talk on the COVID and its impact on health costs, we have to take into consideration these elements that I just mentioned that prevent us to make analysis that is enough and to arrive to solid conclusions. So, having this cleared, I'm going to refer to some specific topics, perhaps to give some clues on the possible impacts. But I would also say that it was to guide this complex discussion, even to make an exercise of knowledge systematization. So I resume several issues that I am going to mention. The first one is that one can observe the different effort at the country level. So the documents that you have online, some of them trying to make a systematization of the scarce knowledge that we have today, the impact could have been very different, indeed very different among different countries. We're talking in cost and expenditure impact. So we could thought that limited budget countries evidently could have a lower impact on the expenditure and the costs. So this is a fallacy, because we couldn't have to mention it. So according this effort, another point is the increase of services related to COVID demand versus the demand of other health service demand. And we find out that there is a effect on demand that comes from the reaction of the people that we could resume as a change of conduct of the users regarding a risk, which is really expected in a crisis situation as this one. So an example is the demand contraction of health services. But perhaps we could have other examples that basically refer that the people have several fear to assist to this as health establishment, fearing they could be could have the COVID-19. This generated another kind of demand. So this is documented in some countries, sometimes in a general way, not with systematized information. Another point, the third one, it referred to the readjustment of offer of the health systems and the reubication of a budget. We could say that practically all the countries ran to readjust its offer services, as we mentioned at the introduction, strengthening the offer to attend COVID-19. But in a lot of cases, also in parallel, decreasing the offer in other sectors. For example, postponing surgeries, closing of specific services, redistribution of hospitalary spaces, reconditioning health services and health infrastructure to attend COVID-19. So we have to take this into consideration. Consequently, we could conclude that there exists a readequation of the offer with a contraction, with a budget contraction. When we combine both effects, the demand contraction and the contraction of the budget in other areas, we could have two scenarios. The first one would be full compensation and the expansion of specific offer regarding COVID, and the expansion of the expenditure in specific services. When we see the documentation, the documents of the countries, there are some evidence of these scenarios. A fourth point is the use of a special budget for health contingencies. Some countries that had institution of security systems use this reservation that could have minimized the expenditure on other areas, or at least to make a budget readjustment. And therefore, I couldn't say that in those countries one could expect a positive effect when we saw the main expenditure on health services. The fifth point is the different ways on which this budget was used, and of course, the different effects that this caused. Expansion of expenditure made on taxes, for example, where the government make a special expenditure, including the tax systems, or for example, from the tax systems, helping or aiding the health system financing by the taxes. In some cases, the contraction of public health services, whether private or public, in some other countries, there was an important increase of health costs, for example, to replace with a personal effort of health services where there had been a readequation or contraction of the offer. The people had to respond with its own pocket money. So we have to analyze whether we want to see the total expense. We have to take this private expenditure into consideration. So the experiences could be very varied. So as we can see, this presents some additional difficulties to conclude on the total effect in the expenditure on health systems. A sixth issue could be the demand accumulation and expenditure disposition. We could say sanitary passive. This means the offer contraction and, re-adequation, budget re-adequation associated, that would imply to attend to the in the future patient that wouldn't be attended because on accelerated demand by the offer contraction of the services. I personally have listened to expert to refer this point. I believe that this is a very valid analysis, but at the same time, are very difficult to analyze and measure because it implies intertemporal measurements that are very complicated. And they are really challenging. A last point. I don't mean that this is the last one, but I am trying to resume an effect of the increased cost. Let's talk about the semi-variable expenditure in health. And despite the re-adequation of offer and demand that we have already talked, an important expenditure of health costs followed a normal course because it's a fixed expenditure. For example, the expenditure on human capital that couldn't contract. It is very difficult to get rid of human resources on public services because we're talking of agents, of workers that are working there under civil services. The topic of infrastructure, and these generate, of course, a special expenditure. So with this, there is also the hiring of new staff to maintain the demand on the COVID-19 problem. This didn't generate a proportional expansion of the expenditure. So as we can see, to make a complete analysis, there we should have to take into consideration series of analysis, a very detailed one, and to make a measurement, or to make or to have an idea, a wide idea. It's very complex because we have to also take into consideration the reality of each country. So I'm going to cite here some examples from the Economist Intelligence Unit, which generated this is a work of beginning of 2021, and it says contrary to the intuition, the expenditure of the health assistance has diminished during the COVID-19 pandemic, even though they're having a lot of budget to attend the virus. The patients have been far from the hospital by fearing they will have the virus. In this inform, they examine the impact of COVID-19 pandemic that will have and will have in the sanitary health services. So it's prevent that the GDP is contracted in the G20 countries that are analyzing this inform. It is expected that the sanitary expenditure will recover. So we have here an example of the contraction example of indicators. To calculate the impact it's contracted, for example, the economical activity, and this can lead to an economical recovery worldwide provoked by an increase, let's say, an increase measured on the costs. For example, I gather this information of the COVID-19 pandemic has as a direct effect a diminishing of the pre-existing services. This is in Mexico. In Mexico, in 2020, the consultation for 7 diseases decreased in 48.5% less than in 2019, as well as less attention and the increase of the family, the expenditure that the families made on payment of medicines and consultations increase. That is to say, 9.7% it increased in the Mexican budget in 2021. This is cited by several NGO. In Spain, for example, the Diario Pharma, on informations of pharmaceutical economics, said COVID increased the sanitary expenditure in 2020 in a 10.9% record number. So we can see through these examples that there are different effects between different countries of effects that could be contradictory, but they require an analysis. I would say, to conclude, that the COVID-19 crisis generated a generalized answer of health systems with different grades of reaches, and I would say with different impacts on the expenditure and cost and total cost in health systems, because one is a relative and another an absolute measurement. Also, we have to say, to conclude, that there are methodological difficulties, methodologies, denominators, indicators, database to make any solid conclusion. And we could talk of expansion effect services and expenditure that we would call specific expenditure and cost COVID-19, the contract and expenditure on health systems, and as a different total effects in different countries. Another conclusion would be that we must invest on the analysis of this wide range of information that is really complex to systematize. But I believe that this is an exercise that must be done. This is a critical exercise. So the health authorities are better prepared and face future pandemics. So we also know how to face this pandemic, this future pandemic crisis. So I leave it here, and thank you very much. Thank you very much, Dr. Fabio. It is very interesting, your reflection of this topic and how to have a different vision on what was COVID-19 impact through mentioning the expenditures as this variable that also is part of GDP, how this was modified during the adequations were made. And indeed, we have to make still a lot of work to systematize what you are saying, how it affected differently to these countries and how this information was generated. Well, we still need time to process it and make the correct analysis. Thank you very much for your participation. Later, we will have a space for questions and answers. We will continue with this webinar. Now is the time of Dr. Maria Luisa Mariño. She's a sociologist, doctor of social policies of the Warwick University. She works in the Division of Social Development of CLAC. She is a technical focal point on disability issues and also works in the areas of health, labor inclusion, and social protection. Previously, she worked at the ECLAC sub-regional headquarters in Mexico City on research on the labor inclusion of women and social stratification in Central America and Mexico, as well as on technical advice on the 2030 Agenda for Sustainable Development. Before joining CLAC, she was a researcher at the Fundación Espacio Público and worked for the United Nations program in Chile. We welcome you and give the floor to Dr. Maria Luisa Martinion, and it's a pleasure to have you with us. Thank you very much. Good evening or good day, according where you are. Thank you very much for the invitation to participate in this such important space, and that we keep informating ourselves of what was the impact of the pandemic in the region, considering that there will be a lot of things that we cannot still gather all the information. I'm going to share my screen. First of all, I would like to thank the Inter-American Center for Social Security Studies. Greetings, cordial greetings for Dr. Daisy Corrales Diaz, which is the director of this center, as well as Maestro Jorge Alberto, because he extended us the invitation, as well as Dr. Fabio. Very interesting the exposition of Dr. Fabio Duran. I'm going to make another perspective on the impact of the pandemic, making an analysis of the different impact that having the social, sanitary, and economical impact. Briefly, almost 2.5 years after the start of the pandemic, which remains forced, the triggered health and social crisis persist in the region in a context of uncertainty for economic recovery due to the different world inequalities, and as well of the lack of financial sustainability that have this recovery process. The second aspect that I'm going to highlight in my presentation is that in this Latin America and the Caribbean has been shown to be particularly vulnerable to the pandemic. This is explained because the inequality, structural inequality, as well as the pandemic, the social and economical gaps have been deepened that impact the health of the population. All of this have make evidence the structural weakness of health systems in Latin America and the Caribbean. Have also become evident chronic underfunding, fragmentation, and segmentation of these systems. And from the pandemic constitute an historical opportunity to debate, promote, and implement reforms to health systems that allow progress toward universal, comprehensive, and sustainable health systems, and promote public policies with a comprehensive approach, such as health, economy, and social protection. So after almost 2.5 years of pandemic, the health and social crisis was triggered persist in the regions. The gaps have deepened. The social and economic impacts that was deepened in the health of the population. The region's vulnerability to the pandemic, we are talking on the disproportion in terms of COVID-19 deaths in and excess mortality. This graphic shows how the 20 countries on Latin America has been in 2020 and 2021 was more than the double. than the mortality excess in Europe. No country in Europe has an excess mortality rate higher than the average excess in mortality in Latin America. The mortality excess we have used as an indicator that reflects very well what has been the impact of pandemic sanitary issues in the population, because it considers not only the deaths that has confirmed by COVID-19, but also all the other kind of deaths that could have been by that was not classified correctly by COVID-19, or also death triggered by the sanitary crisis and the displacement crisis that has that we had of other diseases that were displaced, and we will see it later. It's also important to mention that the WHO has estimates that the region has had nearly 2.3 million excess death during the first 2 years of the pandemic, which correspond to the 15.3% of the world's excess mortality. So this is confirmed that this proportion in these issues, because the population of Latin America and the Caribbean represents 8.4 of the world population. This is a tendency that we have seen regarding COVID-19 deaths, the confirmed COVID-19 deaths, that in the region represents the 27% of COVID-19 confirmed deaths, being 8.4 of the world population. This is also leads to the deep vulnerability in this region. So the impact of the pandemic has also been unequal. And we have to emphasize that we have to lead to this universal health system. And we have seen that excess mortality during the pandemic in the region has been higher in those countries with higher levels of informal jobs. Let's say whether the countries have more informal jobs, higher is it the excess of mortality. This trend is also observed in those countries where there are higher levels of poverty and extreme poverty. I'm going to share you after the presentation a link of a publication that we have released regarding an analysis of the COVID-19 evolution that precisely make this kind of analysis and show how inequalities have been a very important issue during the pandemics. So this kind of graphics confirm that health inequalities during the pandemic and the unequal distribution of the social determinants of health has deepened. And this has been closely linked to the core of social inequality, which from the CLAC has defined as the axis that determine social structural inequality in our region. This emphasizes the need to move toward the universal health systems, which have to be articulated with social protection system, and to prevent the major vulnerability of informal workers, because in a lot of informal workers weren't able to follow these sanitary measurements, and they wouldn't be able to follow these social activities. Another, we have identified certain groups that we have called invisibilized, because in the beginning of the pandemic, the COVID-19 was focused on the most vulnerable population. The last part of 2021, we started to identify some groups that were not being really attended. Regarding the economic, social, and health crises that were triggered by the pandemic. For example, we have children and teenagers between 9 and 7%. The mandatory vaccines, for example, or of the basic scheme of the first years of life were stopped. As well, we have seen the infantilization of poverty regarding when the pandemic started. We also know that there has been an impact on mental health mental health impact on children in quarantine measurements, and also because the amount of population that lost its personal caregivers, as well as mental health impact globally. Additionally, we have seen the impact on the class interruption and the need of implementing teleeducation with all the inequalities gaps that mark this process, whether the inequality in terms of digital infrastructure, as well as the access of computer or internet connection. Another groups that have been invisibilized were the indigenous people, for example, through the vaccination process, which has not been accessible, not cultural pertinence. We don't have specifically the statistic information in these towns, a similar case for the disabled people. So we have a lack of statistic information of confirmed case and deaths by COVID. Of 2021, we saw that this population didn't have a vaccination process taking into consideration their special needs. So this is very important to reflect on health system that advance in a universalism sensitive to differences, respecting the principle of universalism, and a universal gap would be capable to implement policies that face the gaps by these population groups. The social crisis keeps going on, and we can see that it has been impacting poverty, inequality, and extreme poverty in the region. Between 2020, in 2020, poverty and extreme poverty increased for the sixth consecutive year in the region. The increase was so big that in 2021, despite the recovery, a recall of 27 years is projected with increasing poverty extreme. Regarding what we had advanced in the case of extreme poverty. Between 2019 and 2020, regarding the Gini coefficient, it increased by 0.7 as a regional average, and we see that there is a tendency of an increased tendency by 2.9 in 2020. Sorry, it's the first time that the Gini coefficient increased in the region. This is also measured in terms of education, as I was saying. There has been some impact that we haven't been able to measure. For example, the impact in the development and skills of the students whom faced the longest period of closing of educational centers. Of course, the pandemic has also had a social impact in the labor market, with a deepening of gender inequality and income quintiles. regarding gender, we can see a regression in women's labor participation of 18 years. And we also see that between 2021 and the projections that has been done to 2022, the market recovery, the labor market recovery has been unequal between men and women. The most poor quintiles have been, of course, the most damaged. Also because of the informal labor that decreased in 2020, but has been recovering these 2 years, 2020 and 21. The economies, whether the economies are showing recovery effects, but they haven't been enough to recover the employment levels pre-pandemic times. It's an economical recovery that will remain unsustainable by the lack of equality in all its measures. So to close this section of the impact of the pandemic and how the social crisis is still going on, as well as the sanitary crisis, we can see that the impact of the COVID-19 pandemic are unequal, but as well they deepened the social inequalities. I share a diagram in which we state that inequality that is so characteristic of our region, a structural inequality, is a cause and effect of the major vulnerability of the pandemic. And in this sense, the pandemic description can be associated to a syndemy, an interaction between the biological pandemic dimensions with the socio-economical characteristics of Latin America and the Caribbean population. That increase the probability of infection and death by COVID-19. The social and economic impact of the pandemic reproduces and exacerbates the inequalities that existed before, as we see in the other graphic. And as we have seen, related to poverty and extreme poverty. At the same time, the social and economic impact recently described of the pandemic reproduces the inequality. For example, when we have a more proportion of informal workers before the pandemic and having more levels of extreme poverty and a lot of other health determinants that deepened the unequal distribution of the pandemic. Therefore, that increased the risk of death by COVID-19, as we show in this diagram, the relation between the inequality distribution of and the major diseases of the most vulnerable population are related. This relation has as a base the weakness and the structural gaps of health system and social protection systems of the region, and the need to reform and strengthen these systems to reduce health inequalities. And therefore, this leads to a new equilibrium of the social of the population. As we said, as I was saying, the countries of the region has to face the crisis, the pandemic crisis, with health systems and social security systems that make difficult to control the pandemic. And in this sense, a first aspect that I would like to mention is the topic of the historical weakness in health and social protection systems. We know indeed that the public expenditure of the region is lower is lower by recommended by PHO, and this leads to a high out-of-pocket expenditure. That in each home they had to spend 33% more of total health compared to the 21% of the countries. This make difficult the access to the health infrastructure, as we will see more detailedly. Additionally, we are trying of these segmented systems of health systems that deliver different quality systems, whether the attention and organization of health systems are fragmented, which difficulted the quality of the delivery of the quality systems. I would like to show you here one of the clearest expressions of underfunding of health systems, which are access barriers that faced by the populations. For example, the average availability of doctors per inhabitants and health infrastructure are lower than the average of the OCDE countries and the WHO recommendation. This is a very important factor in order to guarantee health access to the population. In the region, the average in primary attention is lower than the 30% of public spending on health that the PHO recommended. In the context of previous weakness in health systems, led that the population face more obstacle to have to access health systems and health services. We have here the displacement effect. In this graphic, there are some calculations of 2020 and previous years regarding the mortality excess. We can see here how many people came out of the hospital less than the previous years. In Peru, for example, we see a decreasing almost of minus 56% of attention in cancer diseases. And of course, this does not reflect that the population health were better during 2020, but that the population couldn't have access to the hospital due to the COVID-19 pandemic disease. And this chain on fatal, indeed, the displacement was caused both by the reorganization of health services and by the population's fear of infection. This was the displacement effect in the country report disruption in all types of health services and 55% for primary care. This effect displacement, meaning the diseases that were not COVID-19 answered by the health services reorganization. The displacement effect is indeed associated with to the excess of mortality. All the obstacle related with historical health system problems were added to the displacement effect in hospitals, and this translated that indeed there has been more levels of excess of mortality. At the third year of the pandemic, this situation has not been solved, and indeed the countries of the region are going to strengthen their institutional capacities, and as well in terms of health investment to answer to this um, to all these problems that were due uh, due to the pandemic and the historical problems of health institutions. The analyzed data shows that indeed there are millions of people that were not able to access the health services because lack of money, because they couldn't afford to pay the requirement to be attended. This is very important to have this into consideration. So the access to and mass vaccination processes has been also marked by inequality in duration. The data that I present to you are of May 21. So we have that a lot of countries have vaccinated more than 50% of the population. We can see a strong equality between Latin America, because between countries of Latin America and the countries of the Caribbean, and indeed this is related with inequalities and the asymmetries that exist between the developed and developed countries, as well as a regional fragmentation due to the buying of the vaccines. ECLAC has mentioned several times in different moments the need and the integration and cooperation, whether regional and sub-regional, to guarantee the universal access to vaccines. Also, prior to the vaccine, we have several gaps regarding social security. We see here that in 2019, less than the half of the economic active population contributed to pension systems. And in 2020, the pension coverage of economically active population reached 44.7, a fall of 2.1 percentage points compared to 2019. This means a 10-year decline. Pension. So the people in age of having its pension were not able to have its pensions. I would like to also show you, in terms of social protection, non-contributive social protection, there were gaps previous to the pandemic and was deepened due to the COVID-19 pandemic, despite the efforts that the countries have made. On one of the main tools that the countries used during the pandemic to support unemployment were the unemployment insurances. This exists only for 8 countries on the region, and we can see in this the amount of the people who receive this insurance, this kind of insurance, and so the amount of money expended in that also increased. This has been also accompanied with other measurements, such as the flexibilization of the requisite to have this insurance. The countries acted quickly and implemented several measures to address the deficit of permanent universal and social protection instruments. Quickly, we show the accumulation between 2020 and 2021 of the monetary transferences that were the main tool used by the region, as well as the transfer products and basic services. And finally, to close, I would like to highlight as a closing that indeed, from ECLAC, we consider that the pandemic constitutes an opportunity to debate, push forward, and implement reforms to health systems, which are reforms or that the health systems been gathering from a long years, and that is have this made difficult the handling of the crisis. In this diagram, I would like to reflect that the catastrophic impact of the pandemic in the region has made on evidence the challenges that the health and social protection systems have. In this sense, COVID-19 pandemic that triggered a sanitary crisis, and then the vicious circle started on economical crisis, social crisis, has put make an evidence the centrality that health has in social in inclusive economic and sustainable social development, and the profound interdependence that exists between the social, economic, and environment dimensions. This highlights the importance to have policies that articulate the social dimension as well as the economic and the environment dimensions. So I would like to highlight in this historical moment that we have in front of us to reform all the health systems to make sure the total universal inclusiveness and sustainability of health system. In order to, it's necessary greater investment in health systems to avoid sub-financing globally, and special emphasis in the first care attention. This investment must be sustainable financially and accompanied by a more efficiently organization in health systems. And it's also important to consider in this reform, these models, this fragmentation of health services, and to think in more efficient ways of coordinating the different services. And in this is fundamental, as I mentioned, to strengthen the first level of attention. And this strengthen must be in line with a strategy of first that would incorporate the basic health services. This is fundamental to avoid the inequalities that are reproduced socially and economically. This should be accompanied by promoting comprehensive policies that articulate health systems and health policies with universal, comprehensive, and sustainable social protection systems within the framework of care societies. To finish, I would like to say that health is not just about health. The debate on health reforms is transversal to the society. By reforming the health systems, the fiscal resources are committed that have impact beyond health systems. These reforms on health systems must be accompanied by a social pact that is centered in equality and human rights. And this social pact has to be also linked to a fiscal pact that guarantees the financial sustainability of health systems and move toward a welfare state. And of course, of a resilience for future pandemic crisis. Thank you very much for your attention. Thank you very much, Doctora Maria Luisa. I think you have give us a wide vision and an excellent resume of what has been the pandemic in this third year. We can see indeed that you present the dates of what has been the pandemic in all the region. Indeed, we must highlight to that health system access should be universal, and that the coverage should be free and quality. I believe that it's also important to mention that We have to make a greater investment in health so we can indeed talk on health system sustainability. At least in this American Commission on Actuary and Funding, we keep making the study and the analysis of the information. And indeed, what is related with the social and the politic, we are talking on the repercussion of the pandemic regarding on how the homes were affected. A simple example is how they had to spend extra money to have oxygen because there was a lack of services in the worst years of the pandemic. So thank you very much, Doctor, for your presentation. So now we are going to give a floor to our third panelist of this webinar. She is Dr. Leticia Martinez Martinion. She is Director of Actuarial Studies of the Superintendence of Health and Labor Risks in the Dominican Republic. She is Coordinator of the Actuarial Calculation Specialty, Life and Pensions of the Technological Institute of Santo Domingo. She's actuary by the Faculty of Sciences at the National Autonomous University of Mexico. She holds a master's degree on actuarial management of Social Security at the Faculty of Economics in the University of Buenos Aires, Argentina. She's demographer by the Latin American Center of Demography in San Jose, Costa Rica. She has a specialty in multivariate methods from INEGI CIMAT, Mexico. So we will welcome Doctora Leticia Martinez Martinion, and it's an honor to have you here with us today. I will give you the floor. Thank you very much for the invitation. And especially thank you very much of taking into consideration the Superintendence of Health and Labor Risks. It's a pleasure to have listened to the two panelists because it gives me a very interesting framework on what we do, those who articulate an insurance model and the coverage impact. To visualize and understand the elements that are key to health attention within the Dominican Republic, we have here a regulatory framework and an insurance framework where they are coordinated in order to give this health protection to the majority of the population. We have national health systems in which the health minister is the one who makes the policies. And the social security system is the financing and pension regulator. Here we have the structure of the health system, and this is very important. It's very important to understand it, to know how the answer was based facing COVID-19 and how the attention was organized from the social security and in coordination with the national health system. So we have the contributory regime on social security. We also have a contributor system, a subsidiated regime that has a health insurance guaranteed from within the social security system, where the health administrations are in charge of manage that health and to authorize those health services through the public and private health services. Here be all the services that the familiar health system insurance have. We have a basic health plan where outlined the health coverage that are financed with the contributive regime of the workers, and and as well as the subsidiated regime, what the state is have 100% subsidied. We also have the health, the insurance risk work. We have services associated to the health through an accident, laboral accident. So you see here a scenario of what are we following, or how are we surveillance the pandemic from the beginning with the first case, and how it's evolved through all these almost 3 years. Yeah, almost 3 years. So we were listening in the previous panelist the mortality rate by COVID-19 in Dominican Republic that are within the lowest in Latin America, according, as I saw in the comparative. Well, Costa Rica has a lower level, and then it follows by Dominican Republic. The topic is the health coverage and the articulation with Social Security and the associated costs. We can see here a diagram in which, as we focus on giving the answer and how we were able to guarantee certain elements, such as to keep the population coverage, to the familiars insurance in all its parts, not only in health issues, but in economical services, such as subsidies. These subsidies by common disease, by maternity leave. The second element was the access to PCR tests for all the population. The third one, to guarantee the health system to emergency attention hospitalization, and all the infrastructure that the population with COVID-19 needed. And the fourth one was a guarantee to all the protection equipment for the medical and staff personnel in hospital in COVID-19. Not only doctors and nurses, but all those who were related to the attention of COVID-19 patients. The fifth one was the guarantee of medical attention to all the population that had COVID-19, reducing the co-payments, guaranteeing the attention without maximum coverage limits. Because the health system has several limits. 6, the inclusion of 2 million of people without coverage of the I'm so sorry, something happened with my computer. So I'm going to share my presentation again. So we were seeing the inclusion of the 2 millions. It recognized as a professional disease for all the health service and vaccine access. So As a first point here, on April the 2nd, by the Poder Ejecutivo decree created a solidary assistance fund to employment with two modalities. The first one for the companies that should continue operating, subsidies were established so they could keep the workers. And the second one for those companies who must close and under the authorization of the work ministry, the temporal suspension of work contracts were held in the subsidies programs that have included coverage preservation of the familiar insurance with its dependents, direct and additional dependents, even though they stop having this job. This would to guarantee and the continuity of having a health coverage. To keep this fund, the Ministry of Health have different agreements in which they assume that this fund of the contributory regime is going to guarantee the dispersion, meaning the value per capita that given to the risk administration, so they guarantee the protection of the basic health plan. With this, the workers wouldn't be working. Those workers up to February 2020, and all these workers that has been suspended, the fund guarantee that these workers and this job interruption and this interruption in the cotization in the contributive regime wouldn't impact in the affiliation of that population to the health services, which keeps, so the population keeps affiliated to the contributive regime financed by this fund. To keep this element that is a fund in the contributive regime is an element that have any the state makes a unique and extraordinary a fund to the fund equivalent to 5,460 pesos, used to keep the coverage of all the affiliated population, by which it was not the cotization of the active companies that were inscribed in this fund were helped. In 2020, the state make their restitution of this fund. So this guaranteed the continuation of the workers in the contributive regime. So regarding the test for the PCR test for all the population, meaning that the guarantees to have this PCR test was established as a public policy. On March 2020, it was decided that the government would assume the cost of all the PCR tests in private labs for those people who had medical prescription and presented 2 or more symptoms and would have 59 years and older. On that same year, it announced that the state would guarantee this PCR test to all the population through the Dominican system of Social Security. So they will be covered for all the population of the familiar insurance services, and also for all the transitory special plans for pensions. The government approved the coverage to PCR test for all the affiliated people and non-affiliated, while the epidemiological emergency would last. The mechanism to the PCR was structured from the Social Security, using the government to authorize and to pay all the health services for them to ask for to the superintendents of health and labor risks in the Dominican Republic, who validated the sent documentation. Once validated this documentation, the superintendents would emit a solicitude for the payment of the PCR test, and the funds would make this payment for the private labs. In July 2020, they announced that all those people who make these tests to diagnose a COVID on any national laboratory would look for the results online, going directly to the webpage of the Public Ministry. National Lab was overwhelmed, by which private labs came to support and help in order to guarantee their response, and it could be obtained all the PCR tests. So during 2020 and 2021, there has been really a lot of negotiations. So the PCR would be part of the basic health plan coverage, and the familiar health insurance would be assumed, and it wouldn't depend on governmental funds. But due to the price of PCR tests has been impossible. So the price of PCR, it's cost about 4,500 pesos from the Dominican Republic. Nowadays, the PCR is openly commercialized in labs, and only is freely guaranteed through the Ministry of Health, and are processed by the National Laboratory. Nowadays, there has been on 31st of March of 2021, the government administered $150 million to the coverage, and to support the coverage, and to use that mechanisms, and it was reimbursed. The guarantees of health services for emergency attention from within the high-level decision to manage the evolution of the pandemic and decrease the number of mortality for lack of attention. It was disposed increase of the medical attention for clinical handling of suspected and confirmed cases. For this end, the contingency plan was organized, and it was proposed the increasing of public, private, military, and policial public health system, as well as to increase the hospital capacities regarding human resources, materials, equipment, beds, physical space, and the protectional equipment, personal equipment as well. To guarantee the continuity and access to beds, the government supported the coverage of the high cost excesses of all the infrastructure that the COVID-19 needed. the coverage, the high coverage costs, and the handling of corpse in private clinics. In the when the first case was registered in the Dominican Republic, has habilitated for health establishment of the public web and one of the military infrastructure. In October 2020, the infrastructure increased almost 40 times to reach the 151 centers of public attention and two military infrastructure facilities, as well as 56 private hospitals for the attention. The last information checked in June 30, 2021, indicated that in the country there has 2,718 beds for COVID cases. Here's it's an important element in what was the cost to guarantee the protection equipment for medical staff and all the people who were around the patients. So an alliance was established with the National Association of Private Clinics to widen the disponibility of the patient COVID-19 patients and to adjust the costs to increase the availability of beds. This implies also an important investment on protectional equipment for personal private staff who ask governmental support to buy the protection equipment in the handling of patients and corpse. It was established the cost for patient, whether emergency hospitalization, beds, and diseases. All the equipment, the personal equipment protection was analyzed, and the financial charge was really, really big and was made from the government. It has been guaranteeing the coverage through the familiar health insurance. We also established that an increase on all the medical staff from 800 pesos to 2,000 pesos. This also guarantee medical attention to all the contagiated population and was hospitalized. It was 100% guaranteed all the services, erasing all the maximum coverage payments and all the other extra payments from the insurance. So, for example, this kind of exercises, how we structure at the beginning of the pandemic, how we structure all that distribution according to the attention unit, but also according to the medical staff and all the health workers that was helping or aiding in the intervention of these patients. So when we have a guarantee the protection equipment and the medical attention and all the doctors, well, we we calculated to cover all the services, the medical attention for COVID-19 patients is calculated as the resulting sum of multiplying the per capita value of 31.68 per people per month per the affiliated population of the contributive regime. We multiplied that with the value per capita of the GDP regarding the subsidiated regime and the special health pension and plans. So the population was increased substantially. The governmental support in order to visualize some elements. In terms of these medical attentions, we can see here the dispersion, the total dispersion from April to December according to the regime, the funding regime. There has been also an element that you were listening from the other panelists, and this is how, even though having this protection from within a catalog of services, there exists an overusing and an effect of over emergency for that population. In June 2020, the sanitary emergency plan was established from within the health familiar insurance on the health coverage that are not covered by the basic health plan, but it should be given to the population as a response facing the COVID-19 pandemic. This coverage of the emergency sanitary plan would be useful we realized a study where the economical impact was measured as a response of the familiar health insurance. To study the increase of other diseases that were associated to this health familiar insurance. So in order to see the excess, we have to classify the population in PCR affiliated population, those who had negative and positive PCR test, and those affiliated that fulfill with the attention COVID protocol and a negative PCR test, and those who couldn't fulfill the established protocol, it was proceeded to soften the exigence of some coverage. Sorry. Could you help us, because we are over time? These elements lead the state to absorb 3.4 million pesos. Another element is so we have the coverage of the 90% of the population. These state policies supported that every population in 2020 would have a coverage over 95%. which implied that any health demand within the health familiar insurance would be guaranteed. By other way, it was recognized, COVID-19 was recognized as an occupational disease. We have here the access of the vaccination access to all the population, as well as the state financial for all the things that I have told you. There has been also an element that took from the Solidarity Assistance Fund, and then the pandemic developed a lot of damage that has a lot of years unattended. So the final reflections, I'm going to have one, which is the visualization of a national health system integrated, where the response to the attention of health would be the main axis, where all the health system and social security system may guarantee the attention independently of who's paying or financing. Each benefit defined by the social security system would be backed by the cotisation rate and the subsidiated financing that back also the benefits with the same quality and opportunity to contributive financing. And of course, the visualization of a reservation for any future catastrophic events. Thank you very much, Dr. Leticia Martinez. So sorry. Don't worry, these technical problems can happen. So it's very important to highlight what has been done in Dominican Republic and all the medical institutions and how they apply all these policies to reduce rate transmission, make a bigger funding on health systems, and their hospitalary reconversion, which has been the most important and the one that has been in all the countries. So we are going to go now to the question and answer session. We have here two questions. The first one said, following chronic pathologies and earlier identification stages, which would be the impact of the associated effect to late diagnosis or complications? Another question, the pathology incidences and preventive policies proposed would increase the statistic in Latin America region. So we leave the microphone open. I don't know who would like to answer. Dr. Maria Elisa, perhaps. Thank you very much. Well, thank you very much for the exposition of the other panelists, which I believe they were very interesting. And taking the question on the pathologies and early identification strategies, what been seeing from ECLAC is that indeed this displacement effect to COVID-19 generated an interruption on the of a good diagnosis, and as well as chronic diseases or transmissible diseases that doubtless would have an effect on the epidemiological profile on the region, and as well as the statistics and on the regional statistic on this subject. And of course, part of their mortality excess rate on the region answers as well to the lack of opportune assistance that can be preventable, because if we have an opportune if we have a prompt diagnose, we have a prompt response, and this decreases the mortality excess. Thank you very much, Maria Luisa. I don't know if you would like to add something, Doctora Leticia? Yes. Precisely in the final part, it's to strengthen that linked and implementation of primary attention as prevention in some countries. It's already existed, but some others it doesn't. We're starting to make those policies, but we don't have that still. And the other element is how to guarantee. I don't know whether the pandemic makes or visualize that there has not been attention, or the context of those diseases, and how the lack articulation of response capacity of facing chronic and high cost diseases, where integral attention and financing are bound together. So I don't know whether one was the first or the second, but already the pandemic reveals us that we have to focus on the articulation and the guaranteeing of the primary attention. Thank you very much. To close this webinar, we will have give the floor to the president of the American Commission on Actuarial Funding. Basically, is to thank the panelists, Fabian, Maria Luisa, and Leticia, for its excellent investigation that we dimension all the sequels and all the disaster that the COVID-19 pandemic gave us. But as every Latin American country, I'm sure that we will go through all this disaster more strong to fight for the universality and the solidarity of social security and health services. I was interested particularly in the intervention of the Doctora Maria Luisa, which she mentioned the problems of the extreme poverty in our region, because it's indeed a region that we have a very vulnerable population, and all the situation that we have already been fighting, and in a certain way, we had managed to help and to overcome some needs regarding poverty, but the economy indirectly at the beginning of the pandemic was affected, but nowadays it's a direct impact on companies that had to close, and therefore the unemployment have aggravated the acquisitive power of the workers around Latin America and the Caribbean. Regarding the spending on health, particularly in Panama, it has an important investment in vaccine topics, for example. Panama has managed to put 8.8 million vaccines. We are in the fourth wave still, but of course, Panama didn't escape the economical crisis that affected us, and that is that we are suffering right now For example, the prices that we have to face this extraordinary event around the world. Thank you very much, Fabio, Maria Luisa, Leticia. For us, it's really a pleasure to have such high-level panelists with us in this webinar of the American Commission on Actuarial Funding. That is part of the Inter-American Center for Social Security Studies and the Inter-American Conference on Social Security, to the Maestro Jorge Alberto Romero and Dr. Daisy Corrales. Thank you very much. I hope to have you with us in future events. Thank you very much to all the panelists for accepting participating in this webinar to show all these very relevant topics. And please don't forget to visit our social media and the microsites of the American Commissions. Thank you very much to all, and goodbye.